الربيع وفاء المطار أحب الوفاء بشتى الصور أحب الوفي الأمين الأغر فأهل Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to the Medical Files, brought to you by the Islamic Medical Association of South Africa, your weekly health segment where we go beyond the headlines and dive into the health issues that truly matter to you and your loved ones. We're broadcasting live tonight from our Durban studios on Radio Al Ansar, and we also welcome the listeners of Radio Islam, Channel Islam, IFM, Voice of the Cape, Sirius FM, and Radio 786. I'm your host, Dr. Zakaria Ahmed Ismail. I'm a medical officer working in the state sector in Durban. And tonight we're talking all about osteoarthritis. So to introduce tonight's topic, let me ask you this. How many people dismiss joint pain as just getting old? How many find themselves slowing down, unable to climb stairs, unable to kneel in prayer, thinking it's just normal wear and tear? How many families watch their loved ones struggle with pain daily, unaware that proper treatment could bring relief and mobility back to them? Osteoarthritis is not just about aging joints. It's about mobility, it's about dignity, and it's about living life without pain. And tonight we're going to unpack what it really is, why it happens, and how it can be managed effectively. And joining us tonight for this important discussion are two esteemed orthopedic surgeons with us tonight. Dr. Syed Mia, whose name many of you will recognize for his extensive work in hip and knee joint and reconstructive surgery, as well as Dr. CHETTY, an orthopedic surgeon with a passion for spinal injuries and getting people back on their feet, literally. Welcome to Medical Files, Dr. Mia and Dr. CHETTY, and thank you for both for joining us tonight.
Hi, Dr. Zach. Thanks for inviting us.
Assalamu alaikum. Thanks for having us here on the show.
Pleasure to have you all. And to our listeners, this is your show too. If you have any questions, any thoughts, or any personal experiences to share, send us a WhatsApp on 060-904-1056. That's 060-904-1056. Don't wait until pain limits your life. Tonight is your chance to learn, to ask, and take control of your health. So stay tuned as we explore what osteoarthritis is, who it affects, and how it can be managed. This is Medical Files. Tonight we're choosing awareness over avoidance and empowerment over pain. So let's start by laying the foundation. Before we can talk about prevention, risk factors, or treatment of osteoarthritis, we need to understand what osteoarthritis actually is. It's a term many people hear, but few truly understand what it is. So, Dr. Mia, can you explain to us what exactly is osteoarthritis?
So, in simple terms, osteoarthritis, so we have synovial joints, and the synovial joints is lined up with cartilage. And so when you get wearing out of the cartilage, that's in simple terms, then you get essentially loss of the cartilage, and then you get bone on bone contact. And usually this is associated with your symptoms as pain, inflammation, and stiffness of the joint. So essentially it's just wearing out of the cartilage.
And a question for you, Dr. CHETTY. So how does osteoarthritis then differ from other types of arthritis? There's a lot of other types of arthritis out there.
Arthritis is inflammation of the joint. So basically what it is, osteoarthritis is the aging, the degeneration of the actual joint itself. I always say picture yourself as a car. Picture yourself as an engine, multiple parts, your knees and your hips, almost like your tires and things like that. So as your tires get worn out, as your brake discs get worn out, as your engine gets worn out, that's part of the degenerative type of system that occurs, or the change in the body. That's the osteoarthritis it is. The other types of arthritis you get is mostly like, your things like rheumatoid, psoriatic arthropathy. Rheumatoid is quite common in the population. I would say those are ones that are sort of slightly different, but the same type of pathology, joint pain, stiffness, and things like that. And the key to it is to understand that that osteoarthritis is probably more age-related, whereas the other pathologies are probably more related to a disease itself. Osteoarthritis is not a disease. It might be a disease of the elderly or the disease of an aging system, but the other ones are diseases which can be changed with medication, changed with medical treatment, rather than sort of surgical treatment where we come in. So it's important to make that differentiation. And the key to making that differentiation is to understand the presentation of the patient. So if you've got a young patient who's developing joint pain and developing atypical joint pain, that's where we sort of teach our medical students, we teach our GPs, and we teach our registrars to recognize that type of pain. And that's pathological type of pain. Right. So when it comes to understanding what osteoarthritic pain is versus pathological, pathological is the one that really makes you sick. It's the one where you're waking up at night, severe burning in a sort of joints. The pain sort of moves around the place and things like that. You're losing weight. You're not getting better. Your fever, temperature is also sort of related to it. And for me, it's that night pain. It's that throbbing type of toothache pain that'll give you more that pathological pain where you're going to worry about the other types of arthritis. Now, you ask yourself, what's osteoarthritis? It's everything that pathological pain is not. So it's often related. If you sleep, if you rest, if you don't move, the pain gets better. With time, the pain does get better. With less movement, the pain gets better. And you don't typically have what we call constitutional symptoms, where you're losing weight, or often you're putting on weight because you're not moving so much. And the medication yourself you take for degenerative pain often helps. For pathological pain, you've got to take more and more and more tablets, or you've got to visit the doctor more and more often. And you find that you're losing weight, you're not feeling well, there's a fever, that's the one you've got to watch out for. That's the one that we have to look at. I call it the wolf in sheep's clothing. So when you look at those type of pain, when you're speaking to your doctor, explain to him that this is what I'm feeling and this is what I think is going on, so that he can also be suspicious of it. So that's the key, is understanding the patterns of pain.
Would you describe it as a mechanical, very simply put, a mechanical type of pain?
Exactly that. It's an engine in your car. The osteoarthritis is a mechanical pain. So when you have a patient who's sitting in front, it's something that I teach in my lectures to the chiropractors, physios, bios, dentists, pharmacists and things. It's understand that patient's pain. So classify the pain that they're feeling. Is it mechanical, which is a diagnosis by exclusion? So you've got to make sure this patient doesn't have inflammatory pain. This patient doesn't have referred pain, because you get patients with back pain that might have kidney stones, females often with their genitourinary system, infections and things like that. That can all cause back pain, joint pain and things like that. And that's part of why you'd go and see your doctor and you'd explain that type of pain for him. And you'd expect him to sort of unpack that for you especially when you're visiting for the first time. Yeah.
And then coming back to you then, Dr. Mia, with this wear and tear type of arthritis or osteoarthritis, which joints are most commonly affected?
So just coming back to what Dr. Chetty said, so essentially it's very important to diagnose, to differentiate between inflammatory type of pain and the osteoarthritis. So either inflammatory arthritis and osteoarthritis. So osteoarthritis is more a degenerative type of pain. We say mechanical, simple wear and tear kind of pain. Right. But essentially the joints that are affected, most joints can be affected, but essentially your knees, your hip, your spine, your fingers, and then obviously less commonly is your elbows and your shoulder joints as well. But all your joints can be affected, any of your synovial joints.
It's the ones you cut out the most, eh? Yeah. So by far, the three most common is the reason that what we do here. It's your weight-bearing joints, it's your hips, your knees, and the spine.
Now, as you said, the weight-bearing joints. Dr. Chetty, can you expand on some of the early warning signs that our listeners should never ignore with regards to their pain?
Yeah, no, definitely. So, it's the pathological type of back pain, and it's a pathological type of pain in general. And the thing is, it's night pain. For me, there's three things I always used to study, or I sort of try to teach people to understand the three most important things. Number one, it's the night pain. So what happens is during the night, if you're waking up because of this pain, if something's throbbing and I always describe it as a toothache. If any of us had had toothache, any of the listeners have had a toothache, during the day you seem to be okay. You take some aspirin, you take some Panado over the counter, put some cloves in that thing, and you're feeling all right. But then at night while you're sleeping, you wake up and you feel like you want to pull your tooth out. You literally, I mean, I've had it once or twice. I want to pull that tooth out. It's that kind of pain that you got to worry about.
Okay.
The second thing is that if you're losing weight, you can't sleep, you're taking a lot more medication than you're normally taking, and you're not just feeling well and you're feeling tired all the time, that's a constitutional type of symptom that you got to watch out for. The third one is that if you constantly got to go back to your doctor, and you're just not getting well, and you feel that you constantly have to go back to him, and each time you go back, you're sort of getting better with an injection, and then it sort of comes back after 3 days, and then you're going back again to him, getting another injection and things, and you've got to take much more leave from work and things, and it's affecting your lifestyle, it's affecting your happiness, it's affecting your
daily activities.
Exactly. I mean, that's the type of pain that you've really got to get sorted out or treat medically.
Should our listeners be worried if they're having pain during movements, if they start losing their flexibility, if they get stiffness after resting? Is that worrisome as well?
Yeah, definitely. The morning stiffness is a problem. Stiffness or it's degenerative pain is for me is a diagnosis by exclusion.
Okay.
So as long as you're not getting that kind of pain, if you're getting improvement with movement, if you're doing a little bit of physio, a little bit of exercise, Pilates, yoga, great things. So if you're feeling that stiffness and you decide to rehab yourself or change your lifestyle to improve it and it's getting better, then great. That for me would be mechanical pain.
Okay.
Pain that gets better with rest, pain that gets better over time, or pain like the stiffness, you can unlock that stiffness. If the stiffness starts getting difficult, if you've got to take multiple pain medication and go back to the doctor, take injections in that joint, that's the one you've got to worry about. So definitely mechanical pain is more something that gets better with time or with rest or with rehabilitation and lifestyle change.
Just to come in there, I think it's important also, like in osteoarthritis, if you're having those symptoms, that pain, stiffness, and that early morning stiffness, and that as your symptoms get worse and your disease progresses, then rather seek treatment early. Go and get it checked out. Make sure you get it treated there. So that's more on the mechanical side on your osteoarthritis. You see.
So these are some of the warning signs that our listeners should be aware of. And then again with you, Dr. Mia, with osteoarthritis, is there a typical age group? Do you see it in older people? Can you get it in younger people? What have you seen so far?
So that's the thing that we used to say, it was a myth that we used to say this is a disease of old age. But there's obviously increasing frequency as you get older, but we are seeing much more younger patients with osteoarthritis. Usually the arthritis that the patients have younger, they are usually post-traumatic or they either genetic. So we are definitely seeing more younger patients with osteoarthritis.
Would you say sports plays a role in the younger population?
So with a lot of sports injuries, especially now with the introduction of pedal, astro, and we got middle-aged
all shoulder and elbow intense.
You want to be younger. You want to feel younger. We're having a lot of sports injuries. So obviously when you have these sports injuries, you obviously have damage to your cartilage as time goes on with repetitive strain on those joints. And then you are getting more earlier osteoarthritis.
Earlier onsets of the disease. And Dr. Chetty, do you see any differences in genders between male, female with osteoarthritis?
It really depends on sort of what you did in your early life.
Okay.
So for me, when I look at x-rays of patients with osteoarthritis, I tell them, look, it's basically a picture of what you did when you were younger. If you were lifting up heavy car tires or putting in engines, or I've got a lot of time for females because, a lot of them say, no, they don't do much work, but they took care of 4 kids. You were pregnant 4 times. Your body really took a beating, and the fact that you've got kids that you pick up, you move around, you're driving, you're getting in and out, and things like that. So your X-rays, or the fact that you've got degenerative arthritis, is a testament to how you lived your life early on. So I could look at somebody's X-rays, especially their spine, their hips, and their knees. And you can tell, look, this person worked really hard in their life. And with the advent of science and the fact that we're living much longer, it was just 200 years ago that our life expectancy was 30, 40 years. Now it's up to 70, 80, we've got 90, we've got centurions living in the world at the moment. And that's why we're seeing these X-rays with accelerated degenerative arthritis. The science is getting better. And it's a testament to how hard you worked. So whatever you do in your life, if you were a heavy weightlifter or bodybuilder, and as much as you can be up until the age of 30. By the time you hit 40, and that's the barrier for me, and it was a barrier for me personally, was by the time I hit 40 was I realized everything I did in my life before is now catching up with me. And you've got to listen to your body. You've got to understand that, listen, you can't do what you did when you were 25 years old. You can't play 2 action cricket games or 2 paddle games in a row and then decide, listen, you're going to go operate and things
Your body
like that.
starts
Your body
talking back
starts
to you.
talking back to you. And if you don't listen to it, you're going to be in trouble.
I think the predominance of the sex there is that usually, I think between under 50 years, it's more common in males.
Okay.
And I think between 50 and 70, I think it's more common in females. But then afterwards, it equals out.
Okay,
So the predominance
out
Yeah.
of the male and female is predominantly equal.
Well, thank you, doctors. That gives us a clear picture of how osteoarthritis develops, how it affects people's daily lives. But understanding what it is only half the story. I'm sure you'll agree with me. The next step is understanding why it happens. What are the causes? What puts some people at higher risk? We spoke a little bit about that, but we're going to touch more on the myths that prevent people from getting the right treatment. So in our next segment, we're going to explore a little bit about that. If you've just tuned in, we are talking about osteoarthritis, the most common form of arthritis, with orthopedic surgeons Dr. Syed Mia and Dr. Rinesh Chetty. So far, we've covered what osteoarthritis is and how it presents. Now we're going to go a little bit deeper into the common misconceptions that often lead people down the wrong path. So Dr. Chetty, starting with you, what would you say, or would you say that many think osteoarthritis is just a part of aging? Would you say that is true?
Yeah, no, definitely. It's for me, it's true. When I think about osteoarthritis, it's part of the degenerative mechanical nature of what the body's saying to you as we sort of carry on in our older lifetime. It's a testament to how hard you lived your life. And like I said, as you get a bit older, you're gonna get it much more. So it's about understanding and listening to your body as much as osteoarthritis affects everybody. So it's the 3 things I say. There's 3 certainties in life. We're all gonna die at some time. We all got to pay taxes, no matter how much we want to avoid it. And you are going to get some form of back pain, knee pain, or hip pain in your life. How you handle either 3, it depends on how you want to live your life and understand it, and how you want to benefit or function from it. So in terms of taxes, that's always going to give you a headache. Death, we can't do much. But when it comes to back pain, knee pain, hip pain, we can do things. The science has been remarkable. And the fact that we are living longer, and the fact that you can do an operation for it, can change your lifespan and change your quality of life. So back pain, knee pain, hip pain, it doesn't need to put you down. It doesn't need to debilitate you in bed. 40, 50 years ago, put you in the bed and say, look, auntie, take Panado and relax now. And then, call everybody and say goodbye to auntie. Now, auntie can still go run the marathon if she wants you. That's the technology that's come out. And the key is to know when to do it, and who to go to, and how to recover from it, and what do you do after that. That's the key. That's what it's about
improving your quality of life.
Exactly.
And Dr. Mia, have you come across any myths with regards to osteoarthritis in your practice? Misconceptions.
So there are quite a few misconceptions.
Supplements.
The supplements is one of the big things that
we've heard things about glucosamine, about collagen. Are these helpful?
Rather
controversial.
So essentially, no. So then we manage osteoarthritis a few ways. First of all, we look at all the non-operative measures. Okay. So first of all, the most important thing is your lifestyle modification. So essentially, if you are overweight, first thing we start is the weight. So because that automatically takes all the pressure off your joints.
As you said earlier, the weight-bearing joints.
Yes, weight-bearing joints. Yeah. So we start with the weight. In fact, I just want to elaborate on the weight. We have a cutoff when we do surgery as well, like a knee replacement or a hip replacement. We have a BMI cutoff of like 40. We use so internationally they're using 35, but in our country we have high BMI, so we use 40 in the government sector.
BMI,
so BMI is a body mass index. It uses your height and your weight, and it tells you whether you are obese or not obese. Okay, so essentially we use a body mass index, and what we've done is we found that patients that are over BMI of 40, that we don't do surgery on them, because we found that those patients, the surgery is not lasting as long as it's supposed to, like 30 to 40 years. It's lasting 5 years and they're failing, and then they're having another revision surgery, bigger surgery. So those patients that we send them away to lose weight, they actually come back. A lot of them, a vast majority of them come back once they lose weight. They say, "Doctor, I'm feeling well. I don't need surgery anymore." So it's amazing that your weight plays such a big role in this, in osteoarthritis.
So we try tackling that major risk factor before we even talk about
It's
any.
by far the most important risk factor. In your 5 kgs, I tell patients, if you lose 5 kgs, you change your life. For every 1 kg of weight, every 1 kg of weight you lose, you take about 5 kgs of pressure off your knee. So, I mean, that's amazing. I mean, so you lose 5 kgs, that's 25 kgs off your knee, and it allows your knee to actually breathe and move and things. So, I mean, that's for me is key when I make decisions on surgery. We make decisions. It's weight. And if there's one lifestyle change you can make, it's change your diet and lose weight. You know, cut out bread from your diet if you want to. I mean, you can spend all that money on glucosamine and spend all that money on BKLD and what's the other funny thing. I think save your money and go buy healthy food. And lose 5 kgs, and then, you know, that's the best supplement you could do for yourself. Smoking,
the diet plays a big role. Diet, smoking.
Smoking.
Can you elaborate on smoking and how it affects the joints?
So smoking, essentially, it affects healing. When you do surgery, it affects the healing of the joints. As far as osteoarthritis is concerned, I don't think there's any direct
it's an
positive
indirect
factor.
thing,
It's an indirect positive factor for osteoarthritis.
Indirectly.
Before surgery, during surgery, after surgery, smoking is a thing that just cuts down the blood. Cuts down blood to the joint, cuts down blood to the body. Patients have difficulty before surgery, after surgery. So if you are planning surgery or considering surgery, like Syed said, you're slightly overweight, you know, there's 3 things you can control without needing to worry about supplements. And you'd rather save your money and eat healthy, lose 5 kgs. If you are smoking, stop smoking. And that takes about 2 to 3 weeks to sort of stop smoking. You okay? You've got arthritis. So you just stop smoking. Right. Stop smoking or cut down the amount of smoking you have. And then the third one is forgot now, you changed your chair, but control your comorbidities.
So it's about controlling your lifestyle, changing your diet.
All these other things.
That's tackling one of the major risk factors that contributes to
100%.
osteoarthritis.
Yeah, the diabetes plays a big role as well. So if you have diabetes and you got osteoarthritis and you need to go for surgery, then we do a blood test called hemoglobin A1C. Essentially, it's just checking your 3 months average glucose levels. And if they are above 7, then you're already at high risk for a infection post-op. So essentially, you should rather get your diabetes under control before you do any surgery.
Before we look at any surgical options.
It's a biopsychosocial model. You just want to make sure you stop smoking, lose weight, control your comorbidities, make yourself the best opportunity to treat yourself conservatively. And then if you do need surgery, then give yourself the best opportunity to have it.
Like coming back to another myth that I've come across, weather and the joints. Now in Durban, we're fortunate to have summer almost all year round. What about the cold weather? Does that affect the joints?
So yeah, definitely. There's no direct effect of the cold weather, but it doesn't affect your osteoarthritis, but it does affect your symptoms. So your pain is worse when it is cold. And also, besides having osteoarthritis and the cold weather affecting your symptoms, when you have surgery and you have metalware inserted in your body, then when it's cold, and especially like now we've had a little bit more severe winter in this winter, lots of patients have been feeling a slight discomfort or a little bit severe pain, but which settles obviously once the weather gets better.
What is that link? Why does the cold worsen the pain? Does it have to do with the musculature, the muscles?
Probably all of it. Probably the blood supply, the fact the vasoconstriction going towards the joint, the stiffness of the actual joint itself, and the fact that the muscles also get stiff. Often patients say, "Look, I've sprained my ankle. Should I use heat or should I use cold?" The thing is, it depends on what your body feels. Certain people feel better with cold. Certain people feel better with warm. You know what I mean? But with regards to like exactly what Syed said, is that during cold weather, you do find patients get a lot more pain. That's why keeping your joints warm, putting on one of those tubey grips, using one of those over-counter things, keeping it deep heat works lovely, especially at night, Voltaren gel, etc. So improving the blood supply to the joint, i.e. keeping it warmer, would definitely help with the pain.
I advise my patients with hips and knees to either get long stockings, or what works better is to get a long socks.
Yeah,
It's in the winter time.
It keeps it just stable.
Obviously, long johns is the
especially
other
with
thing.
sciatica as well. A compression stocking works very nicely. Things that you rather spend money on than glucose.
Well, there's some really eye-opening points there. And to our listeners, osteoarthritis is not inevitable. It's not a life sentence. It's something that can be managed. I think from what we've heard so far, can be treated, and in many cases slowed down dramatically through early intervention. If you've just joined us, this is Medical Files. We're talking to orthopedic surgeons Dr. Syed Mia and Dr. Rinesh Chetty about osteoarthritis, what causes it, how to recognize it, and how to stay one step ahead. We're going to take a short break now, but when we come back, we'll focus on how osteoarthritis is diagnosed, what treatment options are available, and what you can do to keep your joints healthy for life. So stay tuned. You're listening to Medical Files, your trusted guide to health awareness and empowerment.
Teaching you something new every day. Radio Al Ansar.
This hadith is sponsored by Ashraful Aid, International Humanitarian Organization.
Hadith a day. قال رسول الله صلى الله عليه وسلم خير الناس أنفعهم للناس. The best of people is one who benefits others. We should always help others. We must sacrifice ourselves and our things to help others. When we help others, they will love us and they will make dua for us.
This hadith is sponsored by Ashraful Aid, International Humanitarian Organization.
Are you looking for a meaningful way to fulfill your zakat obligation? Look no further than Ashraful Aid. With our trusted track record, your zakat reaches those who need it the most in the most honorable and dignified manner. Visit our website at www.ashrafulaid.org.
Sunnah a Day, proudly brought to you by Sunpick, 100% pure sunflower cooking oil. Sunpick, cook more with less.
Sunnah a day. Wash the hands and gargle the mouth before sitting down to eat.
Sunnah a Day, proudly brought to you by Sunpick, 100% pure sunflower cooking oil. Sunpick, cook more with less.
Imagine this. You're putting together a 7-color meal, from the creamy pasta to the glazed carrots and flavorful onion gravy. This entire meal is made with our 100% pure extra virgin olive oil from our La Familia range, bringing outstanding quality and taste to your kitchen. Shop La Familia 100% pure extra virgin olive oil at any leading supermarkets near you. La Familia, heart of the home.
At this time of trial and worry, the blessings of charity are the ideal means to avoid calamity and despair. The Al Imdad Foundation gives you the opportunity to sponsor a share in a borehole in South Africa for just 1,000 rand and provide what the Holy Prophet, peace be upon him, called the best form of charity. Donate online at alimdad.com or call 0861 786 243 for more information.
At Checkstar, we got the best deals. Snowflake cake flour, 10 kgs for just $109.99. Pantene shampoo or conditioner, take both for just $119.99. Offers valid until 19th of October 2025. Only at Checkstar Mount Edgecombe, Durban CBD, and Sparks Road branches. T's and C's do apply. Checkstar really cares.
Radio Al Ansar, 24/7. 365.
Doctors and guests on a Medical Files program will help you with any medical problems you have by giving you advice on air. However, they do not have your full medical history and they have not seen you. Please verify the advice given to you on air with your doctor who knows you better. Neither the doctors nor Radio Al Ansar will be held responsible for any ill health caused by the advice given on Radio Al Ansar.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the Medical Files, brought to you by the Islamic Medical Association of South Africa, your trusted source for medical insight and awareness. I'm your host, Dr. Zakaria Ahmed Ismail, and tonight we're joined by two orthopedic surgeons, Dr. Syed Mia, Dr. Rinesh Chetty, as we continue our conversation and discussion on osteoarthritis. So before the break, we unpacked the causes. We spoke about some of the risk factors behind this joint condition. Now we're going to shift our focus to screening, diagnosis, and modern treatment options available, right from conservative care to advanced surgical techniques. So far we've learned that osteoarthritis is more than just an age-related issue. It's a complex condition. It's influenced by your lifestyle, by injury in the past, by genetics. Now let's turn our attention to detection and management. So Dr. Mia, then when do you think someone should see a doctor with persistent joint pain? At what point should they see the doctor?
So I think if you have the classical symptoms of pain, which is unbearable, or pain which is getting worse as time goes on, if your medication requirements are going up, then obviously you need to seek medical treatment. If the other thing is that deformity, so usually like with knee joints, you either see your knees getting bandy. So normally that's varus osteoarthritis. So if you get some deformity, obviously you need to seek treatment for it then. And then the other one is stiffness. Stiffness is also one of the causes. I mean, one of the symptoms that we should look out for. So you should seek early treatment then with stiffness as well.
What about the patient who, let's say, they're kneeling in prayer and they hear this constant clicking in their knees? Is that something that they should be concerned about?
Yeah, I think so. With the knee, there's a few things to consider. Either you could have a meniscus problem, so you need medical treatment for that. But obviously, if your arthritis is getting more severe, you will struggle to kneel. Like patients that go into sajda, they will have problems. Patients that go to church and they kneel as well, they also have problems. So then, ideally, you should get it checked out then.
And Dr. Chetty, let's say a patient comes to you now with all these symptoms. What are some of the main diagnostic tools that you rely on?
Yeah, so it's always about taking history. I think first off, I mean, Syed's mentioned it, and for me, it's pain. So, it's pain that's just not getting better over time. It's pain that's not improving on medications, and it's pain that's affecting your quality of life. If a patient's presenting to me and it's really, the pain is affecting their whole sort of ability to function, and it's causing depression, or it's causing an affectation on them, actually, whether it's prayer, whether it's social, whether it's work and things like that, that's where we need to start investigating them. And the basic investigation comes with a physical examination. And this is why it's key to have your designated GP. Because your general practitioner is your main sort of guy who will make that differentiation to say, listen, I can give this guy an injection, I can give him some pain medication, we can send him to the physiotherapist, we can do some rest, ice, compression, elevation, change his lifestyle and things like that. And if all that's not working, then your general practitioner is the one that sort of makes the decision, look, we think that this guy's going to need a specialist to see them. What happens is, and especially in South Africa, in the private sector, is you have patients that come to the specialist on their own referral, where they've decided, look, they want to see the orthopedic surgeon because they've got pain in the joint. And the first question I ask them, look, you're sitting in my office now, you're a surgeon, you want to be cut. And the guy says, no, look, I don't want surgery. I said, okay, then you're sort of coming to a surgeon for me to tell you what a general practitioner who could probably do it much more cheaper, much more efficiently, and a much more easier. Because you can see that GP, a good GP, probably the next day, where a good specialist, ideally, you have to wait a couple of weeks for him. And, ideally, the GP would probably do a set of x-rays, examine you, make sure to rule out inflammatory arthritis or referred pain. For example, like, a kidney stone could give you pain referring into your groin and your back. It often gets mixed up with back pain and sciatica. But a good GP would be able to pick that up, do a dipstick in his rooms and things. So a physical examination, investigation with an x-ray will be able to tell you whether you've had an old fracture, whether you've got osteoarthritis, osteophytes, weakening of the joint. These are all synonyms for arthritis. And, a lot of the time patients would read these x-rays, see this massive essay, but in the end of the day, it's basically just arthritis and different forms of severity of it. So that would be the baseline of investigations. Before you're going into any of your MRI scans, bone scans, and all these other things that we can do, the thing is your GP doing a good physical examination, ruling out pathological back pain, giving you over-the-counter medications or conservative treatment, doing the x-rays, making the diagnosis, that's key. Once that's done, And if it's not working, then that's when you need to see the specialist.
Right.
And that's when we know that we'll start doing the advanced investigations after that.
Advanced investigations obviously would be your CT scan or your MRI scan.
Right.
But your MRI, MRI will tell us what's happening with your soft tissues as well as with what's happening with your bone as well.
Okay.
So MRI is very advanced. So usually, like in early forms of, say for example, a patient comes with hip pathology and they have early avascular necrosis of the hip, meaning they have pathological hip. And with those patients, usually the X-ray changes are very minimal. So in those patients, then you would want to consider doing an MRI scan, which would show us more details there.
You're going to rely on something with a bit more detail, as you said. Yeah. Okay. And take us through some of the conservative treatment options. And when I say conservative, I mean non-surgical options that are available currently for osteoarthritis.
Okay, so our conservative options, we always go conservative first, non-operative methods. As he said, as Dr. Chetty said, we use the GP would obviously exhaust all those non-operative options, and then you would want to consider surgery. So the non-operative measures, first of all, lifestyle modifications, as I mentioned. So number one is if you're having joint pain, we can give you walking aids, crutches, or walking frame, or something to offload the joint. Number two is if you're overweight, we ask you to go to the dietitian to lose weight, to offload the joint again there. Then the next thing is you can consider physiotherapy as well. The physio exercise always helps. And then you strengthen the muscles around the joint. That's what the physio does. And then the next thing is pharmacological, the drugs. So usually with the drugs is I usually start, lots of people take Lyrica. And Dr. Chetty knows a lot about Lyrica. But I start with simple analgesics. Start with your Panados, paracetamol and Panado, the first group. And then once that's not working, you can go on to non-steroidal anti-inflammatory drugs. And then afterwards, you can consider your opioids.
Like, Brufen.
Your Brufen, Voltaren, your Indocid, Naproxen. So those are your non-steroidals. And then once that's not helping, then obviously you can go higher, then you can go to your opioids. But you can also, what's commonly used is tramadol, which I don't like, but tramadol is used very commonly in the state sector. So you can consider that. And then obviously then another option is steroids. So steroids, you can either take oral steroids, but we don't recommend oral steroids. The other thing is you can take intra-articular injections. So you can get a cortisone injection into the joint, yes, into the knee joint itself.
I think while we're touching on conservative treatments, a question came through. Listeners asking if magnesium will help to ease the pain and discomfort with osteoarthritis. Chetty, do you want to weigh in on that?
Yeah, I think magnesium is a great, if you are going to take a supplement, especially to help you out. There's a few things that I tell patients that they can do in terms of helping with their joint pain. Besides all the drugs and all medications and things, is sort of these things that you can do in terms of rehabilitation and avoid. So in terms of exercise, especially if it's a weight-bearing joint. Doc, I like going on these long walks on the beach. I like running on the sand. I like going on the promenade from Umhlanga, walking from Addington to Umhlanga and back again. Can I carry on doing that? I'm like, listen, your knee is not looking very good. Your hip's not looking very good. Your spine's not looking very good. Like, let's not walk from Addington to Umhlanga. Let's maybe walk from Addington to North Beach, and then maybe take a break, have a coffee and then maybe break it up a little bit. So cutting down the amount of shock absorption on that joint. So say most of these joints are like tires.
Or swimming.
So that's the thing. So like rather go jump in the ocean.
Repetitive movements.
Exactly. Swimming is great. I mean, provided you can swim. Don't jump in there if you can't. But swimming is great because it takes off weight. It's weightless. So aquatherapy is great. If you're not going to be able to walk, if you're not going to be able to jog, and walking on the beach, unfortunately, is uneven, so it causes problems. I hate the treadmill. I think they should be putting a warning, like the way they put a warning on smoking, they should put a warning on the treadmill. because it's a repetitive nature, and it's almost like taking your tire and you're constantly bouncing it, inevitably at the same spot, and inevitably what's going to happen, that tire is going to burst.
Constant high impact on the joint.
And as much as you might get, I mean, patients get addicted to the adrenaline or the norepinephrine that's released during treadmill training, and I think it's something that needs to be really thought about, especially if you speak to the bios and the physios and the trainers, and those are the guys that, in terms of conservative treatment, that you should be going through. Yoga and Pilates are excellent. Tai Chi, the Chinese knew about it a while ago, and what we've done is we've taken those ancient sort of treatments and we've turned it now into modern in terms of Pilates and yoga. So it's great in order to keep flexibility, improve joint conditioning, and something you can do that's free. That you don't need to spend too much money on. Swimming is great, but magnesium is a wonderful drug to take at night, especially using it at night. If you're feeling a bit of muscle spasm, it's also a little bit of a natural relaxant. And touch wood, you can't theoretically overdose on it, but don't take my word for it.
20 milligrams.
It is a bit cheaper, and it is something that I would advise patients, if they do suffer from cramping and stiffness in muscle, thing is to consider using that. The science is there. The other thing that works very nicely is that if you have a bath, is Epsom salt baths. So the general vasodilatation of a hot muscle soak or bath salts or something works wonderful to keep the spasm down. Your joint is sore, you've just sat in a plane or you've driven 2-3 hours and your back is stiff and it's caught, jump in the shower. A hot shower directed at the spot of spasm
heat on that
works
area.
wonderful for that. A hot water bag and things that also works wonderful. So there's things that you can do that, especially with early degenerative osteoarthritis, that doesn't cost you much, that you can change in your lifestyle. And magnesium, great. If you want to spend some money, I'd much rather you go buy some magnesium over the counter, quite cheap. Take a tablet or two, try it out. If you're taking a lot of magnesium and it's not working, maybe come sit in my office. But it's all about listening to your body and knowing what works for you.
And Dr. Mia, you spoke also about the medication that the patients can use to relieve their pain. You also spoke about the injections that can go into the joints. Does this by any way slow down the disease progression, or does it just help with the pain?
Actually, in no way it slows down the progression of the disease. It's just for control of your symptoms. So usually with the steroid injections, and now you're getting some more fancier steroid injections. So it essentially you repeat it twice a year. It's every 3 to 6 months or so, twice a year. But it's not in any way osteoarthritis. It's not going to slow down your disease. It's just going to control your symptoms.
Just help your pain for a little while.
It's like if you got a damaged tire and you're putting a plug in it, inevitably that tire is going to carry on. If you carry on doing what you're doing with that tire, it's going to burst anyway. So it's sort of a temporizing measure. It's sort of a way to sort of tide you along the place. But once again,
to buy time, to get older, to progress you to get older before you actually do surgery.
So buy you some time. But the problem, said, and is taking multiple injections into that joint can also decrease your chances of having a successful surgery. And ideally that should be administered by a specialist after we've done all the investigations. So constantly getting any joint injection, or before you start taking any steroids, ideally that should be initiated by a specialist, be it a rheumatologist, be it a physician, be it a surgeon and things. I think, like I said, the spot of finding the GP, making the diagnosis, and then referring you on. But taking multiple injections into that joint can be
also the thing is, if you take a cortisone injection, you shouldn't get surgery within 3 months of taking an injection, because you will definitely, your risk of infection is much more higher. So please tell your doctor if you did take a injection before your injection.
And when is the right time then to change that tire, so to speak, to change or replace or look at surgery or joint replacement as an option?
So essentially, once we've exhausted all our non-operative measures, we obviously got clinical imaging, we've got x-rays as well. So in the x-rays, we usually classify our disease. So usually they are in stages. So if we've reached the final stage now of our disease and we feel that this joint is not doing what it's supposed to do, so obviously then you would consider an arthroplasty. So looking at specific joints, well, Dr. Chetty, we can talk about the spine, but looking at specific joints, the hip joint, you can have a total hip replacement. We're doing much more younger patients now. The hip replacement is considered one of the surgeries of the century because 10 out of 10 patients are happy with a hip replacement. And it's a life-changing surgery, actually. So if you are having hip problems, please go get treatment and your life will be altered, especially you've got a limb. You can sort out all those issues. You have limb length, you have shortened leg due to your hip. You can get treatment for that. Then as far as a knee replacement is concerned, knee replacements, we're doing a lot more knee replacements now. And now there's robotically assisted knee replacements. And it is a very successful surgery, but we still find that 8 out of 10 patients are happy. There are always those 2 out of 10 patients that are still have a niggle here and there. We're not sure exactly why, but I think the technology, as it's improving, it's getting better. Then the other thing is that a hip replacement lasts now almost, the new study shows it lasts almost 40 years. The hip replacement, the knee replacement about 30 to 40 years, but the hip replacement going up to 40 years. And then you can replace other joints as well. But before you do replacements, there are some other surgeries that you can consider, like an osteotomy, where we essentially cut the bone and where the area where there's enough weight bearing, we alter that area of weight bearing. So those are surgeries that your surgeon can discuss with you. But definitely replacements are progressing. I think the numbers are increasing exponentially.
Technology is great.
Yeah.
And Dr. Chetty, then if a patient who has osteoarthritis on the spine, what are some of the surgical options then?
Yeah, so Mia, what you said, 10 out of 10 for the hip, 8 out of 10 for the knee.
Yeah.
For me, it's like 0 out of 10 for the spine. The thing is that you've got to decide as a patient is like, when do you really want to take that step? Because there's risks involved in it. As much as 10 out of 10 hip replacements or 8 out of 10 knees, spines is even worse. Our recovery rate for spines or degenerative spines, I can probably guarantee you, if I operate on you, about maybe 2 to 3 years of relief before the next part of that spine becomes a problem. The difference with spine surgery as opposed to hips and knees is as much as you can take the tire out in the hip and put a new tire in. Same story. It's like changing the tire. You can't change a spine.
You can't do that.
The spine is the engine, and you can't change the engine in this car. We've got to literally try and make this engine work as hard as it can to get you to function. So when is it the right time to make a hip replacement, knee replacement, be it a scope, be it an osteotomy? It's pain. So it's pain that's just not settling. It's pain that's just out of control. It's pain that's affecting your lifestyle. And it's a pain that's affecting your mental capacity, where number one, you're getting pain where you're not getting any relief. Number two, so it's your mind, body, and soul. So basically, your mind is not managing. You're just constantly in pain. You can't focus. Your body's not managing. You can't function. You can't go to work. You can't do. And then what's happening is it's affecting your depression. It's causing you depression. Your soul is not right because you're in so much of pain. Because inevitably, what was the natural course of that? What's happened is you worked so hard in your life and now your body's talking to you. And in the olden days, we used to put you in the bed and say, Auntie, there you go, goodbye. Now, as doctors, we've come out with the science. We've got great technology. Hip replacements, I love. I tell patients, don't wait. When you've got severe hip arthritis, it's affecting you. Can't get out of the toilet. Your prayer position is very important. I mean, one of the main things when patients come to you and say, we can't go to mosque, can't pray, can't get up and move. And if it's a hip, get it done. The knee, I'd be a little bit more circumspect. The spine, definitely. Look, get a chair, man. Get a chair, sir. Sit down in the chair. The Mulana will make a plan for you. Everybody will make a plan. Right. So, in the end of the day, it's pain. And then when you do decide to take that risk, what are the risks? Because that's the next question. Is, I'm going to do this operation. What are the risks? Right. And when it comes to medicine, and when it comes to science, as much as the papers are there, you are the one that's affected. Your doctor's the captain of the ship. He's the one that has to make that decision. And we've got to make it together. So what are the risks? It's the same risk as crossing a street. If you want to cross that street, because you need to cross that street, because you've decided that, listen, pain, my mind, body, and soul is affected, you can get knocked by the car. Now, how many streets do we cross if we don't get knocked by a car? And that's the risk you take. Because if you're crossing that street and you've decided to have that operation, you need to know that in the right frame of mind, you've got the right heart and brain to say, listen, I need the surgery because my life is affected.
And I understand the risk.
You have to understand the risk is crossing that street. And how many times you get knocked by a car? You don't know, but you can. But this is why it's important to trust your doctor and make sure you have a doctor that you trust, because that doctor must cross the street with you. Because if we get knocked together, and I'm going to be with you and handle any complication that's there. That's the kind of trust you need to have in your doctor, and you need to have in the surgery that you're going for, and understand that those are the risks. Anything can go wrong and will go wrong in science. And the older the patient is, if you're smoking, if you're diabetic, you've got a high BMI, you're doing this, you're doing that, and if you haven't changed your lifestyle, you can't expect surgery to change it. It's got to be a team effort.
It's very important to have that conversation with your patient before deciding any surgical
and the family.
And the family.
Well. Everybody needs to be
speaking
involved.
about the quality of life after the surgery, etc.
Definitely.
Thank you both to Dr. Mia and Dr. Chetty. That was a very insightful discussion that highlights just how much can be done for osteoarthritis when patients act early. To our listeners, joint pain doesn't have to steal your independence. Movement is medicine. Awareness is power. The earlier you seek help, the better your outcome. So unfortunately, that does bring us to the end of tonight's show. Heartfelt thank you to our guests, Dr. Syed Mia, Dr. Ines Chetty. Thank you for joining us this evening.
Yeah.
Thank you very much for having us.
It's been a pleasure. Both orthopedic surgeons, they shared their time with us. They've shared their knowledge with us and experience with us. And again, to our listeners, remember, joint pain is not just a sign of aging. It's your body asking for attention. It's your body speaking to you. Don't normalize pain. Early consultation can prevent years and years of discomfort and disability. Catch us again next week on the Medical Files, brought to you by the Islamic Medical Association of South Africa, as we continue bringing you to health topics that matter. I'm Dr. Zakaria Ahmed Ismail, signing off with a reminder that your body is an amana, a trust, so take care of it and it will take care of you. Until next time, Assalamu alaikum wa rahmatullahi wa barakatuh.
Doctors and guests on the Medical Files program will help you with any medical problems you have by giving you advice on air. However, they do not have your full medical history and they have not seen you. Please verify the advice given to you on air with your doctor who knows you better. Neither the doctors nor